Next is the issue of steroids. Now, what is about all this disease? Because many of your dental patients would not come giving a clear history of steroid use. These are the conditions. The ones in bold are more important because they are more common. Asthma, rheumatic fever, SLE, ulcerative colitis, Crohn's disease and psoriasis are going to be patients who are almost certainly under some form of steroid treatment. What happens and how do you handle steroids? Because you must understand, again, that is the discussion of the emergencies where we mentioned about steroid collapse. Steroid collapse is really bad. If it happens, it's extremely difficult to handle after that. So we do steroid management. And what is the rule for steroid management is extremely simple. It is called the rule of two. And the rule of two is double the dose and always suspect the patient to have adrenal insufficiency if the patient is under steroid. If the patient receives 20 milligram of more of cortisone or its equivalent via oral or parenteral route. Why this is important? Because presently for asthma, plenty of people are getting inhalation steroids. Inhalation steroids do not count. You can carry on normal dental treatment on patients who are getting inhalation steroid or topical application of steroid. It is either in oral or parenteral route for periods of 2 weeks or longer. For periods of 2 weeks, so 2 as in 20 milligram or more of cortisone. For a period of 2 weeks or longer within last 2 years. 20 or more, 2 weeks, 2 years. Double the dose. Rule of two. As simple as that. There is a cutoff of 80 milligram. That means you can keep on increasing, but you go only up to 80 milligram of cortisol or equivalent. Now here is the big trick. The word cortisol and equivalent, because cortisol is not the form of steroid that most patients will be on. So you need to know, and you better have a chart of what is the equivalence chart for steroids. You can have this one also. If you check into Google, you will find this. You will find plenty of forms. I have given the simplest form. You search as long as you get it. So this is the form which will confuse you. Go by this chart, you are confused forever. This is the calculation. You see all sorts of how much hydrocortisone is equivalent to how much cortisol. There is the cortisol 0.8. It's very complicated calculation if you have to find out. So let us make it simple. Cortisol 25 milligram is equivalent to prednisolone 5 milligram. Prednisolone is the commonest form of oral steroid that is given to patients long term. 25 cortisol is equal to 5 because we mentioned before 20 milligram or more of cortisol. That is the cutoff. That is where you decide whether the patient requires steroid curve. So how do you calculate now? 25 milligram cortisol equal to 5 milligram prednisolone. So 25, 5, 20 milligram is 4 milligram. Because why I broke it down is because the calculation always is on the basis of 20 milligram of cortisol. So if a patient is on 4 milligram prednisolone and it's like 5 milligram is the lowest dose available in the market. So even at the lowest dose, it goes above 20 milligram of cortisol. Just understand that. Don't wait for 20 milligram of prednisolone. Many people will not be on 20 milligram of prednisolone. If they are on 10 milligram, that is by far more than 20 milligram of cortisol. So 80 milligram is 16 milligram of prednisolone. So cutoff is 32 milligram of prednisolone. If the patient is having up to 32 milligram of prednisolone, you can only double the dose up to that level. You cannot go beyond that for doubling. If anybody is requiring even more than that, that is a situation where you check for a hospital practitioner to take care. Next topic, asthma and COPD. Forget about this side. It's important, but what is more important is this patient should carry own inhaler. This patient is not for general anesthesia or sedation for procedures which can be done under normal local anesthetic. Sedation, I hate sedation. And we are very fortunate that in India, dental practice is not sedation based. In many of the developed countries, sedation is absolutely commonplace, and all the dentists in the world who have lost registration so far has been almost exclusively in cases of sedation. Sedation, though it is extensively used for dentistry and oral work, it was never meant for that because we work in the airway and sedation is only meant for procedures which are not in the airway. That's why dentistry and sedation doesn't go very well scientifically, though it is used extensively in many countries. We are free to use novel techniques, but this will not be an intelligent novel technique to go for, going for sedation dentistry. Much better is general anesthesia under any circumstance. NSAIDs, as we all know, most of the NSAIDs have got a potential to precipitate asthma in vulnerable individuals. Not every patient will respond to NSAIDs as bad, but it is possible. So avoid NSAIDs unless this is a patient who comes in and says that I have been taking 2-3 ibuprofens every day for the last 10 days for pain. You can safely use the NSAID on this patient because this patient is not prone to getting an asthma attack out of NSAID. Aerosol, like in most of the procedures that we do, we use the drill and create an aerosol. Aerosol is an irritant for the airway. So be careful with it when you are dealing a bad patient of asthma for dentistry.